everyone. I welcome you all to the revision class of Demography and Family Planning. First of all, let me begin with the famous quote of Robert Frost. The woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep and miles to go before I sleep. So at the end of this session, learners will be able to define demography, briefly discuss the different demographic characteristics of India, justify that population pyramid is important for public health, define sex ratio, explain what are the factors behind declining sex ratio in India, what are the measures adopted to correct the situation, justify that sex ratio in India is adverse to women, explain the stages of demographic cycle, justify that India is in the third stage of demographic cycle, enumerate the different factors for high fertility in India, enumerate the fertility indicators and explain the meaning of NRR equal to 1, justify that NRR may be regarded as a superior method to GRR for measuring population growth, explain unmet need for family planning, justify that cafeteria approach is a better approach in family planning program, write in brief the advantages and disadvantages of contraceptive methods which an eligible couple should adopt in different phases of their reproductive life to achieve the small family norm, comment upon the emergency contraceptives, and justify the IUD is not an ideal choice for nulliparous women. To begin with, what is demography? So demography is the scientific study of human population. So it mainly focuses on three important readily observable human phenomenon, that is size, composition and distribution. Now, five demographic processes continuously occurs in nature, that is fertility, mortality, marriage, migration and mobility. So these five demographic processes actually affect the size, composition and distribution, that is demography. So next is the demographic characteristic of India in terms of demographic indicators. This will be discussed in two headings, that is population statistics and vital statistics. So under the population statistics, we have size, sex ratio, density, dependency ratio, birth rate, death rate, natural growth rate, life expectancy at birth, mortality rate, fertility rate. These are under the vital statistics. So India is the second most populous country in the world, 1359 million population as per 2018 and 7th in the land area. So average annual exponential growth rate of India is 1.64%. Crude birth rate 20 births per thousand population as per 2018, and crude death rate was recorded as 6.2 deaths per thousand population. Coming to the age and sex composition of India, in 0 to 14 years age group, males are more than the females. And this 0 to 14 years age group is more in rural areas as compared to the urban areas. The elderly population, elderly population, females are more than males. And when we represent the age and sex in terms of graphical presentation, what we get is age pyramid. So the age pyramid of developing country is having a broad base and a tapering top. Next, we go on to age pyramid. Age pyramid is nothing but the representation of age and sex-wise structure of a population. So, on the x-axis, what we have shown is the percentage of the population. This blue is male, pink is female, and in the y-axis is the age group. Age group has been shown. So, in case of developing countries, we get a broad base while tapering top, just like India. Whereas in developed countries, we get the age pyramid which has a bulge in the middle and has got a narrower base. So whenever there is a phase of transition, means demographic transition or development from the least developed towards development, going to developed countries, the shape of the age pyramid also changes. So that's why age pyramid is important for public health, because we also come to know what is the age distribution, age and sex wise distribution in that population, whether the elderly is more, whether the young age group is more, or whether the reproductive age group is more, and what is the burden on the country based on the age group. So next is the sex ratio. Sex ratio is nothing but the number of females per thousand males. So sex ratio in India is 940 females per thousand males. It is adverse to women in India and it is declining over decades. Now, what are the causes for declining sex ratio? Number one being the male child preference that leads to gender inequity. Then the neglect of the girl child that leads to increased mortality at young age, and female infanticide, female feticide. Higher maternal mortality also contributes to declining sex ratio, and male bias in the enumeration of population also leads to declining sex ratio. To this, the sex determination tests and the abortion services as well as the preconception sex selection facilities acts as a catalyst to declining sex ratio. So what measures are adopted to correct the declining sex ratio in India? So they are in the broad categories with respect to improve the education, empowerment, survival and protection of the girl child, improvement in the legislation, and improvement in the prosperity of the girl child. So what are those measures in India? The number one being the PCPNDT Act, that is the Preconception and Prenatal Diagnostic Techniques, Prohibition of Sex Selection Act. So before and after conception and for regulation of prenatal diagnostic techniques, there is this act is there. The second one being the Beti Bachao Beti Padhao Yojana, which was launched in 2015 with the objectives of gender-based sex selective elimination prevention and ensuring the survival and protection of the girl child, ensuring the education and participation of the girl child. Then there is a recent one, Pradhan Mantri Sukanya Samriddhi Yojana, which was also launched in 2015, in which small deposit scheme has been encouraged for the girl child, and in which high interest rates and tax benefits are being provided. Then there are other schemes like CBSE scholarship scheme or the policy for the girl educations. That's applicable only at the government CBSE schools only. It is applicable only for one girl child per family. So just have a look, have a glance on the central government schemes like Beti Bachao, Beti Padhao, Sukanya Samriddhi Yojana, Balika Samriddhi Yojana, CBSE Udan scheme, National Scheme of Incentive to Girls for Secondary Education, Dhan Lakshmi Yojana. And the some of the popular state government schemes, there are many other schemes, but I have just shown you some of the schemes like in West Bengal, that is Kanya Shri Prakalp Yojana, and other famous are like the Ladli scheme for Haryana, Ladli Lakshmi Madhya Pradesh, Bhagyashree in Karnataka, and Mazi Kanya Bhagyashree scheme from Maharashtra. There are many other schemes. So there are other supporting schemes to prevent the decline in sex ratio like Sarva Shiksha Abhiyan, Rashtriya Madhyamik Shiksha Abhiyan, where there are gender sensitization during training, construction of the toilets for the girls, curriculum reforms and construction of residential quarters for the female teachers. Then many other supportive schemes like engagement of Mahila police volunteers, Kishori Shakti Yojana, and one-stop centers to prevent the women affected with violence, and support to training and employment programs for women. And there are other indirect schemes which indirectly helps in declining sex ratio by preventing the maternal mortality ratios, like the ICD schemes and Pradhan Mantri Matru Vandana Yojana, Janani Suraksha Yojana, JSSK, Pradhan Mantri Surakshit Matritva Abhiyan. So based on what you can explain, you can write it. Next, we continue with the demographic characteristic of India. The infant mortality rate in 2018 was 32 per 1000 live births. Maternal mortality ratio was 122 per lakh live births, and maternal mortality rate was 8.1%. The total dependency ratio for the mid 2016 was 50.55%. Young age dependency ratio was 41.12%, while the old age dependency ratio was 9.39%. The density of the population per square kilometer in India was 401.4 persons per square kilometers, and rural population was 66.5%, urban population was 33.5%. The annual urbanization increase was 2.8%. Maharashtra, the largest urban population of India, and Uttar Pradesh, the largest rural population of the country. Total fertility rate for India in 2017 was 2.3. Indian literacy rate was 74.04%, and life expectancy at birth in 2017 was 67 years for males and 70 years for females. So now we move on to demographic cycle. So each and every country passes through the 5 stages or the 5 stages of the demographic cycles. These are the first stage or the high stationary stage, in which the birth rate is high, the death rate is also very high. High birth rate and death rate cancel each other. As a result, there is no growth rate. So we call it as stationary. And India was there in this stage till the year 1920. This is followed with the second stage. We call it as early expanding. Why? Because the death rate begins to decline, but birth rate is still high. So birth rate more than death rate, so the population is expanding. So examples are some of the South Asian and the African countries. Next, the country moves to the third stage or the late expanding stage, where the birth rate declines but death rate further declines. Population is still expanding because birth rate is still higher than the death rate, and India is currently now in this stage, that is the third stage or the late expanding stage. Next is the fourth stage or the low stationary stage, where the birth rate is low, death rate is also low, and both birth rate and death rate are same. So the population is stationary. So Austria, UK, Sweden, Denmark, Belgium. So these are the examples of the fourth stage. Then next one is the fifth stage or the declining stage, where birth rate declines further, death rate also declines. The birth rate is less than the death rate, so the population is declining. So some of the East European countries like Germany and Hungary are in the fifth stage of demographic cycle. You can easily understand the same with the help of this figure. Yes, you can see in the y-axis the deaths per thousand population and the births per thousand population has been shown. The births has been shown with the pink colored line, and the blue color line the death rates have been shown. With the red color line the total population has been shown. So in these are the 5 stages: 1, 2, 3, 4 and 5, and this is with respect to time. So as there is demographic transition, that means as there are the developments from countries progresses, so from the less developed or least developed country towards the developed countries, so this is how the trend changes. So first of all, the birth rate, death rate being high, so they are stationary and the population remains fixed. Then the birth rate is still high and the death rate begins to decline, but birth rate is still higher than the death rate, so the population is early expanding. In the third stage, birth rate declines further and death rate also declines, but still birth rate is higher than the death rate. So this is the late expanding, population is expanding. In the fourth stage, birth rate also declines further and death rate also declines. Both are equal. Then what happens? They nullify each other. Population is stationary. And after that, what happens? Birth rate declines further. So the population is contracting. We call it as declining. Next, we move on to fertility. By fertility, we mean the actual bearing of children. So what are the different factors that lead to fertility in India? So they are basically attributed to these different factors. If such question comes, you have to broadly remember these broad points and then you can elaborate these points based on the number of marks allotted to each question. So what are these factors like? The universality of the marriage, the lower age at marriage, the low level of literacy, poor level of living, limited use of contraceptives, traditional ways of life, all of this contributes to higher fertility in India. And then there are other factors that affect fertility in India, like what is the place of women in society, what is the value of children in society, whether there are widow remarriages, what about the breastfeeding practices, what about the customs and beliefs, the industrialization and urbanization, better health conditions, housings, opportunities for women, and the local community involvement. Next, we move on to the fertility related statistics. So there are various indicators. The first one is the birth rate. Birth rate, you all know, it is expressed by number of live births during the year per 1,000 estimated median population. Then it is followed by the next rate, that is general fertility rate. So as because median population, the entire population is not exposed to childbearing. So in the general fertility rate, in the denominator we have the mid-year female population who are in the reproductive age group, that is 15 to 44 or 49 years in the same area in the same year. So it is the same formula, but the denominator has been slightly changed. We have median female population of reproductive age group in the same area, same year. Then next one is the general marital fertility rate, where in the denominator it is just like the general fertility rate, but in the denominator the married has been added because not all female reproductive age group are exposed to birth. So in the denominator married has been added. Next comes the age specific fertility rate, where in the we have the number of the in numerator we have the number of live births in a particular age group, and in the denominator we have the median female population of the same age group into 1,000. Now age specific marital fertility rate is just like age specific fertility rate, only in the denominator the marital is added. So you just see in denominator we have the married female population of the same age group. Next we move on to total fertility rate, which is very important. Total fertility rate is an important demographic indicator. So it is the average number of children a woman would have if she were to pass through her reproductive years, bearing children at the same rates as the woman now in each age group. So it is nothing but the summation of the age-specific fertility rate of all the ages. So if the age groups are five are used, then you have to multiply the sum of the rates by 5. So this is the approximate magnitude of the completed family size. Next, the total marital fertility rate. It is nothing but the summation of the age-specific marital fertility rate of all the ages. If you have used the 5 years age group, then you have to multiply the same with 5. So next is the gross reproduction rate. The gross reproduction rate is the average number of girls that would be born to a woman if she experiences the current fertility pattern throughout her reproductive span, assuming no mortality. So it is nothing but the summation of the age-specific fertility rate for female live births, because average number of girls. That's why it is gross reproduction rate. Next is net reproduction rate. It is another very important indicator. It means the number of daughters a newborn girl will bear during her lifetime, assuming fixed age-specific fertility and mortality rates. It is also a demographic indicator. NRR of 1 means attaining approximately the 2-child norm. So if it is less than 1, then the reproductive performance of the population is said to be below replacement level. So it is actually similar to gross reproduction rate. But in case of gross reproduction rate, the mortality has not been taken into account. It is based on age-specific fertility as well as mortality rates. So there are other rates, other indicators like child-woman ratio, pregnancy rate, abortion ratio, marriage rate. So you can go through this. So next, we shall come to the statement that what do we mean by NRR equal to 1 and why NRR is better than GRR. So an NRR of 1 means that each generation of mothers is having exactly enough doctors to replace themselves in the populations. So it represents the extent to which the generations replace themselves. So it is similar to the gross reproduction rate, but takes into account that some females will die before completing their childbearing years. So NRR is more realistic, while GRR is more theoretical, as mortality is inevitable. So in reality, fertility and mortality coexist. That's why NRR is better than GRR. Net reproduction rate is better than the GRR. Now we move on to certain family planning and contraceptive methods based questions. So first, coming to unmet need for family planning. So women with unmet need are those who are fecund and sexually active but are not using any method of contraception and report not wanting any more children or wanting to delay the next child. So what do we mean by that? We mean that there is a gap between the woman's reproductive intentions and their contraceptive behavior or the practice. Whatever they are willing and whatever they are actually practicing. So there is a gap between that. That's why we say it as this is the unmet need. So these are high in the adolescents, migrants, urban slum dwellers, refugees, and the women in the postpartum period. What are the reasons for the unmet need for family planning? So there are many reasons like the limited choice of methods, limited access to contraception, particularly among young people, poorer segments of populations, fear or experience of side effects, cultural or religious opposition, poor quality of available services, users and providers bias, and then gender-based barriers. So now we move on to what do we mean by conventional contraceptive. So conventional contraceptive is a term that is used to denote those methods that require action at the time of sexual intercourse like condoms, like spermicides. Okay, but OCPs and Antara, the injectable contraceptives and others are not the conventional contraceptives. The condoms and spermicides which require the intervention at the time of sexual intercourse is actually conventional contraceptives. So next we move on to cafeteria approach. What do we mean by cafeteria approach? So just like you go to a coffee house and you are being given a menu card, like what do you want? So similarly, we have family planning cafeteria approach. That means to provide a cafeteria choice to offer all the methods from which an individual can choose according to his needs and wishes, and to promote family planning as a way of life. Since you provide a basket of contraceptive choices to the eligible couple and you explain what are the good, what are the benefits, what are the effectiveness, what are the side effects, what are the limitations, what are the contraindications, and based on that the person individualizes his or her needs and wishes and selects the one which is most suited. So family planning methods are broadly, so particularly we'll discuss about the contraceptive methods. So they're broadly divided into spacing methods and the terminal methods. So spacing methods, we have barrier methods, intrauterine devices, hormonal methods, post-conception methods, and miscellaneous methods. So under the barrier methods, we have certain physical methods, chemical methods, and combined methods. Under the terminal methods, we have male sterilization and female sterilization. Now, what is an ideal contraceptive? If you know the features of an ideal contraceptive, then to each and every contraceptive you can add, and you can have a checklist like these factors are present or not, so you can easily write what are the benefits or what are the disadvantages. So an ideal contraceptive should be safe, effective, acceptable, inexpensive, reversible, means it should be reversible. Fertility should be reversible, simple to administer, independent of the coitus, and it should be long lasting enough to obviate frequent administration, and it should require little or no medical supervision. Problem is, in reality we cannot have a single contraceptive which satisfied all of these characteristics of an ideal contraceptive. So first, barrier methods. What are the advantages of barrier methods? So it has got certain contraceptive benefits and certain non-contraceptive benefits. Contraceptive benefits because it has got no side effects like that of the pill or the intrauterine devices. But non-contraceptive benefits are like prevention against sexually transmitted diseases, pelvic inflammatory diseases, and some protection against cervical cancer. There are certain disadvantages. Why? Because they require high degree of motivation on the part of the user. And secondly, these are less effective than the pill or the IUDs. They are effective if used consistently and correctly. So next is the male condom. The advantages being easily available, safe, inexpensive, easy to use, no side effects like compact, disposable, and protections against STD. The disadvantage being it may slip off, tear off during the coitus, and it might interfere with the sexual sensation. Somebody might have allergy to latex, and then the failure rates. So these are the disadvantages of male condoms. Female condoms. So main problem of with the female condom is that these are costly and these are generally not acceptable, and the failure rates are slightly higher than the male condoms. But there are certain advantages that like these are pre-lubricated with silicone, so you don't need to use it in conjunction with the spermicides to make it more effective. Uh, it also provides women with the empowerment, especially in cases of prostitutes, because they don't need to depend for the partners to use the condom, so they themselves can use it. Then these are easily available, safe, easy to use, no side effects, light, compact, and disposable. So next we move on to IUDs. So what are the advantages of IUDs? They're simple, no complex procedures are involved in insertions, no hospitalization is required. Insertion takes only a few minutes, and once inserted it stays for as long as you require, and it is almost inexpensive, reversible by removal of intrauterine devices, free from the systemic metabolic side effects associated with the hormonal pills, has got the highest continuation rate, and does not require continual motivation, just like take a pill daily or have a barrier method consistently. And it is also effective as a post-coital contraceptive if inserted within 5 days of the unprotected intercourse. But there are certain disadvantages, like there can be certain heavy menstruation or bleeding. It's very rare. Sometimes there can be pain. These IUDs can lead to pelvic infection, or somebody. That's why it is said that IUD should not be given to nulliparous women, because once it causes pelvic infection or it can lead to pelvic inflammatory diseases, this pelvic inflammatory disease is very notorious to cause the infertility. So then whole family planning program can actually collapse. So uterine perforations, it can cause pregnancy depending upon the failure rates, and it can lead to ectopic pregnancy. There can be expulsion, and fertility after removal generally takes or occurs within 1 year. And this one you can see is the copper T380A, where the copper is embedded in arms, two sides as well as in the stem. This is multi-load copper 375 intrauterine device, which has a life of 5 years. This has got a life of 10 years. This is currently there in our national family planning program. Then what are the contraindications of intrauterine devices? There are certain absolute contraindications and relative contraindications. Under absolute contraindications, you cannot give IUD to those who are having suspected pregnancy or who are having pelvic inflammatory disease or who are having any unknown vaginal bleeding, cancer of the cervix or previous history of ectopic pregnancy. You cannot give it. And then if the woman is having anemia, menorrhagia, or history of PID since last pregnancy, there's purulent cervical discharge or there's distortion of the uterine cavity, malformation, fibroids, or if the person is unmotivated, then we cannot give the IUDs. Next, we move on to the combined oral pills. So, combined oral pills, this picture you can see, this is the Asha supply of the combined oral pill, Mala N, and this is the free supply by the government of India. So, beneficial effects are certain contraceptive benefit, which is highly effective, and certain non-contraceptive benefit, like it provides protection against benign breast disorders like fibrocystic disease and fibroadenoma. It protects against ovarian cysts, iron deficiency anemia, pelvic inflammatory disease, ectopic pregnancy, and ovarian cancer. But there are lots and lots of adverse effects with the combined oral pills, like they can be cardiovascular effects, particularly like myocardial infarction, cerebral thrombosis, venous thrombosis. These are mainly because of the estrogen component. It can, with increased duration, there can be possible risk of cervical cancer. There are metabolic effects like there is increase in blood pressure, serum lipid is altered with decrease in HDL. Then there can be liver disorders like hepatocellular adenoma, gallbladder disease, cholestatic jaundice. And the estrogen component affects lactation. It affects both the quantity as well as the quality of the breast milk and it leads to premature cessation of lactation. There can be breast tenderness, weight gain, headache, or migraine. So we will not use in case of those who are having breast cancer, genital cancers, those who are having liver disease, those with history of thromboembolism, those who are having cardiac abnormalities, those who have congenital hyperlipidemia, and those with undiagnosed abnormal uterine bleeding. Then there are other special problems which require medical surveillance like age more than 40 years, smoking and age over 35 years, mild hypertension, chronic renal disease, epilepsy, migraine, nursing mother in the first 6 months, diabetes mellitus, gallbladder disease, history of infrequent bleeding, amenorrhea. Next, we move on to progesterone only pills or the mini pills. So these are highly effective. Let us discuss the effectiveness and benefits. Highly effective in breastfeeding women, it is 99%. It is reversible, easy to use. Can be started soon after the childbirth. That is very, very important. It can be used while breastfeeding. It is safe for most women. Does not interfere with the sexual intercourse. Can be provided with by trained non-medical staff. And there is immediate return of the fertility on discontinuation. But there are certain contraindications of POPs. Like you cannot give these POPs to those having history of breast cancer with acute blood clots in deep veins of lungs, severe liver disease, infection, tumor, and those who are taking medicines for the seizures. Now let us discuss what are the limitations or side effects of progesterone only pills. So effectiveness of POPs decreases when breastfeeding stops, and they might cause certain side effects in some women's like they can be irregular bleeding, prolonged bleeding, or no bleeding. They can be even postpartum amenorrhea that may be prolonged in breastfeeding women. Then there can be headache, dizziness, mood changes, breast tenderness, abdominal pain, and nausea. Sometimes ovarian follicles may be enlarged, and it does not protect against STIs and HIVs. The failure rates with typical use in non-breastfeeding is 3 to 10 pregnancy per 100 women, and in breastfeeding women is 1 pregnancy per 100 women. So starting treatment with anticonvulsants or rifampicin need a backup or other methods. Next, we move on to Antara. Antara is the brand name for the injectable medroxyprogesterone acetate. This is also there in our family planning program. So there are certain contraceptive benefits, there are certain non-contraceptive benefits. The contraceptive benefits are the long-term contraceptive benefits because it acts for 3 months. Then it is easy and convenient to use. Then it does not interfere with sexual intercourse or pleasure. It can be used by women of any age of parity or married, whether married or unmarried. Then it does not affect the quality and quantity of the breast milk, and it can be used as immediate postpartum and post-abortion contraceptive. It is very effective and reversible method, but fertility returns 7 to 10 months after last injections. It is safe for even HIV infected women because it does not interfere with the antiretroviral therapy, but it should be taken along with the condoms. What are the non-contraceptive benefits of Antara? So these are like it decreases the menstrual cramps or menorrhagia, prevents anemia, protects against endometrial ovarian cancer, protects against uterine fibroids, reduces the incidence of PIDs, decreases benign breast disease and ovarian cyst, reduces the symptoms of endometriosis, reduces sickle cell crisis, and protects against the ectopic pregnancies. So what are the disadvantages of Antara? There are certain definite disadvantages of Antara, like it decreases the bone mineral density. Then there can be weight gain with the use of Antara. There can be minor alterations of lipid metabolism, fluid or nitrogen balance, glucose tolerance, steroid metabolism, or immune function. The little increased risk of cardiovascular disease, there's rare chance of failure, and irregular prolonged bleeding in first 3 months of use, which is followed by amenorrhea by 1 year. So there are certain limitations, like it does not protect against STI or RTI HIV infections. So once taken, its action cannot be stopped immediately. It causes changes in the menstrual cycle and bleeding. This has to be repeated every 3 months, and the return of the fertility takes 7 to 10 months from the date of last injections. There are certain contraindications for Antara. These are like you cannot use them in breastfeeding women who are less than 6 weeks postpartum, and whenever the blood pressure is 160 by 100 millimeter mercury or more, can't use it, and whenever there is any unexplained vaginal bleeding history, you cannot give Antara. Next, we move on to Chaya. Chaya, which has centroflumin or ormeloxifene. These are the non-steroidal, non-hormonal contraceptive pills. So these are advantages being, these are this one you can see, this is the supply of Chaya, and this is the free government of India supply. So advantages being, these are effective, reversible, return to fertility on stopping the pill is found, safe for women of all the age groups, safe for breastfeeding women even immediately after the childbirth. It is easy to use. It is non-hormonal, non-steroidal, so no tension of having systemic side effects like that of COCs or POPs or MPAs. Does not interfere with sexual intercourse. Can be given to women with history of eclampsia. Does not cause any vaginal bleeding problems. Does not affect platelet aggregation, lipid profile, or HDL cholesterol. There is no teratogenic effect. Effective in managing dysfunctional uterine bleeding and can prevent breast cancer, uterine cancer, and protect against demineralization of bone. But there are certain disadvantages, like there can be delayed period in some women, like 8% of cases. It does not protect against STI or HIV, and there can be failure rate as 1 to 2 pregnancy per 100 women with perfect use. With typical use, the rate is not documented. Now, there are certain contraindications if a woman is having PCOD, cervical hyperplasia, recent history of jaundice or liver disease, severe allergic state, or chronic illness like tuberculosis or renal disease. In these conditions, we cannot use Chaya. That's the brand name is Chaya. So now we move on to what are the eligibility criteria for sterilization. So if a male client comes, then the age should be at least 22 years and less than 60 years. If a female client comes, then the age should be more than 22 years and should be less than 49 years. And they should be ever married. Couple should have at least one child whose age is above 1 year unless the sterilization is medically indicated. The clients or the spouses must not have undergone a sterilization in the past, and clients must be in a sound state of mind so as to understand the full implications of sterilizations. Mentally ill clients must be certified by a psychiatrist, and a statement should be made by the legal guardian or spouse regarding the soundness of the client's state of mind. So now we proceed to the emergency contraceptives. So these are also called the postcoital or the morning after contraception that has to be used within 72 hours of unprotected intercourse. So what are the different methods? We have either intrauterine devices or the hormonal methods. So if you use IUDs as emergency contraceptives, then that has to be inserted within 5 days and preferably copper IUDs. Now, if we are discussing about the hormonal emergency contraceptives, then in our government supply, we have levonorgestrel, 1.5 milligram, one tablet has to be taken within 72 hours of unprotected intercourse. Sometimes you might get supply where there are two tablets, each tablet having 0.75 milligram. Then the one tablet you have to take immediately within 72 hours, and the second tablet you have to take 12 hours after the first dose. If you are having OCPs, having ethinyl estradiol comprising of 50 microgram ethinyl estradiol, then you need to have 2 OCP tablets within 72 hours of unprotected sexual intercourse, and the same dose to be repeated after 12 hours. But if you got low dose OCPs, means having 30 to 35 microgram of ethinyl estradiol, in that case you have to take 4 oral contraceptive pills within 72 hours of unprotected sexual intercourse, and the same dose has to be repeated after 12 hours. One can also take mifepristone 10 mg once within the 72 hours. So emergency contraceptive pills has the brand name is Easy Pill. So in national program, I already told you levonorgestrel 1.5 milligram tablet is available. So now some contraceptive choice questions. So if a newly married couple comes to you, the best one is like condoms for the husband and the OCPs like Mala N for the wives. Those who feel the sexual interference with the pleasure, so they can go for OCPs. Otherwise, OCP, those who have problems of systemic complaints or systemic contraindications, they can go for the condoms. So, a newly married couple can go for condoms or OCPs. For spacing, we have contraceptives. Many contraceptives can be used, preferably IUCD for the women, OCP for women, and condom. Next is what methods of contraception can a breastfeeding mother safely use? So, if you use at right time, then a breastfeeding mother can safely use all of these following contraceptions like lactational amenorrhea. So, lactational amenorrhea is started soon after childbirth up to 6 months. So, if a woman fulfills 3 conditions like fully breastfeeding the baby, does not give the baby any top feed, and the menses have not returned, and the child is less than 6 months of age, that means she is naturally protected against childbirth. Then is a condom that can be used anytime. Intrauterine devices have either to be used within the first 48 hours immediately after delivery or after 6 weeks of after delivery. Then progesterone only pills, they can be used anytime after the childbirth, even before 6 weeks. Centroman or ormeloxifil can be used anytime after the childbirth. Combined oral contraceptives has to be used after 6 months of childbirth who are breastfeeding. Those who are not breastfeeding, for them you can start only after 3 months. So injection MPA, you have to use it after 6 weeks of childbirth. Tubal ligation should be done either within first 7 days following delivery, or you do it after 6 weeks of childbirth. This is with respect to those who are breastfeeding. Then vasectomy can be done anytime. So, what family planning methods you can adopt for a woman who has delivered within 48 hours? So, within 48 hours, you can use IUCD, lactational amenorrhea, progesterone only pills, condoms, centroman, female sterilization within 7 days of delivery, and male sterilization that can be used anytime. What are the family planning options available to a woman who has a history of high blood pressure? Yes, you have to remove OCP. The rest all are there. POPs, LAM, IUCD, centroman, condom, injection, MPA. Only if the BP is less than 160 by 100 millimeter of mercury. Then male and female sterilization. So, I think you have understood when to use which contraceptive. So that's all for today's class. I have not exhaustively covered all the questions in your last 10 years. Some of the questions are still remaining, but I have tried my best to give you a brief guide on how to approach to these professional MBBS questions. Wish you good luck. Thank you.